First speaker, it gives me great honor and privilege to introduce Professor Laurel Stadtmauer. She is a professor in obstetrics and gynecology at the Eastern Virginia Medical School. She obtained her undergraduate studies from the Harvard University in 1976 and graduated from the Albert Einstein College of Medicine. And she is special in many ways because she's got a PhD in molecular pharmacology and had many awards and honors, ACOG Award 2002 and 2005. Biographics she was in the Who's Who in Medicine in 2000. And the list goes on. And she is an excellent robotic surgeon as well. I first met her, I'd like to tell this little story quickly, in Mumbai, and we were all leaving to go back home 2 days before the awful terrorist attacks. So our prayers go out to the families and those who lost their lives there. And I would like to urge you all to also say special prayers to two people who are not here with us today, Mandakini Pariha and Gunashila. They are really well-known IVF practitioners in India. Without further ado, Professor Laurel will speak on the role of androgens in the treatment of patients with low ovarian response, a really difficult topic, but in a usual manner, she will explain to us how best we can handle this problem. Professor Stadtmauer.
Well, thank you for that kind invitation, and I want to thank all the people from India for their hospitality. It's been a wonderful trip, as always. So poor responders, everyone struggles with poor responders. They're up to 25% of women undergoing stimulation. And there's insufficient evidence to support many of the interventions that we do. So we're going to be talking about the evidence here. This is one of our patients, a case study, a 40-year-old para-2. She had a tubal ligation, new partner, low antral follicle count, which is something you see with tubal factor. And first cycle, we started her on an aggressive protocol, high doses of gonadotropins, antagonist protocol, and she was canceled after 5 days of stimulation for a monofollicular response. Second cycle, we decided since she only had one follicle on all the drugs, we would try letrozole, 5 milligrams, followed by lower dose gonadotropins, and she was canceled again for a monofollicular response. Third cycle, we went to a microdose flare, and she had two follicles, and we said if you can get more than 3 follicles, we would go ahead. And then we treated her with DHEA for 5 weeks prior to the stimulation, and then a short OCP protocol, and did another microdose flare protocol, and she had 5 follicles, 3 oocytes, and had transfer of 2 beautiful 8-cell embryos and is pregnant. So some of the low responders, well, advanced maternal age is an automatic. High FSH or high estradiol, low AMH, low antral follicle count. And then sometimes we look at the FSH-LH ratio, so it's important to predict who's going to be a low responder and pick a stimulation protocol that is appropriate. Post-chemotherapy, radiation, post-surgery, immunologic or genetic causes. Now, I am at the Jones Institute, and that is where the first IVF baby in the US was conceived with the Joneses. And Dr. Georgiana Jones, back in 1983, had done some work characterizing the types of responses. And the low responders have low estradiol stimulation, high number of premature LH surges, and she recommended starting with high FSH doses. So some of the management, the microdose flare protocol, antagonist protocols used, the androgens are used, letrozole antagonists, so human growth hormone, and the topic today is androgens. And we had all these, a number of these areas have been covered in the conference so far. We just heard some talks on the estrogen in the late luteal phase. Assisted hatching, cytoplasmic nuclear transfer are all things that have been tried in the past, and we're going to hear some talks about that in the future. So androgens, there are androgen receptors in the granulosa cells, and there's evidence that the androgens will modulate FSH activities in the granulosa cells, and they improve follicle maturation. Now, this has evolved because androgens were bad. You hear about PCO patients with high androgens, and too much androgen is bad. Now, all of a sudden, androgens are good in poor responders. So there's a balance, and the opinion of androgens has changed. There may be this threshold ceiling that's involved. Now, the androgens are produced, testosterone is produced 25% in the adrenal gland, 25% in the ovary, and the rest is peripheral conversion. Androstenedione is about 50-50. DHEA and DHEAS are produced primarily in the adrenal gland. So there's this synergy. There's a picture of the oocyte and showing the crosstalk and the synergy between the granulosa cells and the oocyte. So interventions that may improve pregnancy rates, besides the androgens, are possible day 2 transfer and human growth hormone, which will not be discussed, but we're going to focus on the androgens. Most of the studies have involved testosterone transdermal, the DHEA, and there was a recent survey showing that over 25% of clinics are using it, so I'm going to go over some of the evidence. Aromatase inhibitors, and then the use of LH supplementation, which has been a topic covered today, and low-dose HCG, which increase the androgen production in the fecal cells. The original studies were in monkeys, showing that androgen excess stimulates follicle growth in the monkeys, and it increases the number of pre-antral and early antral follicles in the monkeys. And the first studies in humans were done with DHEA in the year 2000. But we know that PCOS women have increased androgens and have multiple follicles. So this shows that two-gonadotropin theory, where the androgens are produced in the fecal cells, and then they can be converted to estrogens by aromatase in the granulosa cells. So the granulosa cells contain androgen receptors, plus the androgens may be working through the estrogen receptor as well. As everyone knows, fertility declines with age. The antral follicle counts decline with age. And the rate of miscarriages increases with age. So the thought as to why the rate of miscarriages increases with age is due to aneuploidy, and this graph shows that the aneuploidy increases with age, especially over the age of 39. And this Broad and Gleicher in 2005 had a study showing that DHEA reduced the aneuploidy, and they used the FISH PGS screening. So they came up with this theory that DHEA, as I'll show you later, works by increasing recruitment of the earlier follicles, the primordial follicles, the early antral follicles, and their thought is maybe that those follicles do not age with the women as much as the more mature follicles. So the other thing that is also produced in the early antral follicles and the pre-antral follicles is anti-Müllerian hormone, which is also involved with follicle development. So the anti-Müllerian hormone is increased in those small follicles, and if the effect of androgens is at that stage 2, where you have synergism of FSH with androgens in the early antral to antral follicles, and that's the thought as to why the DHEA works, then you should see a correlation between AMH and androgen effect. And some of those studies were looking at that. There's a mouse model where DHEA induces PCOS in the mice, and it also works by increasing the growth of the primary follicles. The first study in humans was by Kessan et al. In 2000, and they showed that in poor responders there was an increase in IGF-1 and oocyte yield. But DHEA really never took off until a number of years later. So After Kassan et al.'s work, Barat and Gleicher did a number of studies, but they were all non-randomized controlled studies. They were more case-controlled studies, and some of them were just retrospective studies. But they did show that the DHEA improved egg and embryo quality and pregnancy rates and decreased miscarriage rates. This is from Kassan et al.'s work showing that the peak estradiol increased in women treated with DHEA. This is an example of 5 women, and there was an increase with the DHEA treatment and an increase with the amount of time of treatment. And the average increase in the patients was 3-fold. So you have to understand a little bit about reproductive aging. There's decrease in quality and there's decrease in quantity. Now, quality has to do with the implantation potential and increased aneuploidy and increase in meiotic non-disjunction, and here are some of the theories, and deficiency in the granulosa cell function. And this is more related to age as opposed to quantity, which is more related to the functional ovarian reserve of the patients. And it also declines with age, but in some women it can decline at an earlier age. So quantity and quality in young women with a lower egg reserve, the quality may not be affected.